one big advantage of being the last speaker is that, in fact, I don't need a really an introduction. You almost presented everything I needed to discuss my presentation. And so the first slide is directly our approach, which is to target essentially the liver with an AAV vector. And then what we thought is that when you target the liver, you have a secreted GAA that can then distribute into the body and rescue the disease at the whole body level. The problem we had when we started this project is that we realized that GAA, being a lysosomal enzyme, in fact is poorly secreted. And we thought that we may improve this secretion by modifying the GAA sequence. What we did is to slightly change the sequence, in particular the start of the GAA, to create what we call a secretable GAA. And then we studied if we, in fact, by this modification, we may have a better efficacy. And here you see that, in fact, this is a study that has been done. You can't see the pointer, sorry. Yeah, here it is. Yeah. So yeah, this is circulating GAA activity in GAA mice, and you can see that we have an improvement here in blue with the secreted GAA. This is a paper that has been published now 2 years ago, and in fact looks like the secreted GAA is better even in survival, in particular if you decrease the dose, and you observe also a better clearance of glycogen in the heart with our secreted GAA, and you have a correction of cardiomegaly, muscle glycogen accumulation, and the correction of muscle strength. As I said, this was the past. But then, one thing we wanted to show is that if we were able to compare this treatment with the secretable GAA and AAV with the ERT administration. So you know, now you probably know how an ERT works. So you have the classical peak and trough kinetics for every ERT administration. And the classical gene therapy, in fact, the advantage of the gene therapy is that in theory you have a stable expression of the protein, and this can be, the point is how this can compare with ERT. And what we know so far is that with our secretable GAA, we can just improve the level, the stable level of expression of GAA, but we still miss the comparison information. And to do that is not that easy, as Pim was saying. In fact, because mice, the GAA knockout mice, the classical mice, die after the administration of 3 ERT. So for this reason, we developed immunosuppressed GAA knockout mice, and then we were able to test up to 9 repeated administration of ERT. And we didn't stop because the mice died, actually. We stopped because it was enough. We thought it was enough, 4 months of treatment with ERT. So we compared this ERT-treated group, which is the group number 1, with 3 different doses of the AAV secreted GAA vector, starting from 2010 to the 12 up to 1010 to the 11, which is a pretty low dose. And these are unpublished results. In the heart, you can clearly see the potential of ERT in red. You see a complete clearance of glycogen. But then, the vector essentially worked similarly. But then when you go to triceps, this is a skeletal muscle, which is quite hard to treat. You do see that ERT actually has no effect at this dose. But then with the GAA vector, secreted GAA vector, you have a dose, and a very nice dose response indeed, with a complete correction at 2 times 10 to the 12 Vg per kilogram. We also characterize one interesting feature of the disease in mice, which is the fiber size. So what you should know is that in a wild-type mouse, what you see in terms of fiber size is that you have a wide distribution, a flat distribution of the fiber size with fiber of any size. when you go into a Pompe mouse, what you see is that the fiber size, the distribution becomes almost a peak with fiber that are all smaller than, in general, than the wild-type fibers. And the interesting thing is that with ERT, we were not able to rescue the fiber size, whereas when we treated with the AAV, we saw a nice dose response with fiber size that actually became almost normal with the highest dose of treatment. Here we also performed some electron microscopy because the ultrastructure of the muscle is different in PBS-treated GAA knockout mice. And here you see, this is a picture, I hope you can clearly see. This is a picture of how a muscle, a normal muscle, appear in electron microscopy. And then whenever you have Pompe disease, what you have, this has been shown a lot of times, then you have accumulation of large glycogen that includes also autophagic material. And with DRT, you don't rescue this phenotype, and you do see this accumulation. But then when you go up with the dose of the AAV-GAA, secreted GAA, you do see an improvement, and then you reach a situation with the highest dose, which is quite similar to what you see in the PBS-treated wild-type animals. And we do have a quantification of this, and you see that, in fact, you have, yes, you can say normalization, even though in wild-type animals, their wild-type muscle is really perfect because these are mice that are only 6 months old, so they are very young animals. And so you have the muscle, which is the structure is completely perfect. Whereas the mice treated with the GAA vector, they still have some difference, but that this is really reduced compared to the ERT-treated or PBS-treated animals. And this also reflected in an improvement in the grip strength. So here you can see this is what we call a grip strength test performed in mice. In fact, you use a grid and you measure the strength of the prehension of mice on the grid. And there is a small difference, but you have to consider that these mice are still alive. So, I mean, they grip the grid anyway. And so the difference is this one from a wild-type mouse and a Pompe mouse at this age. And then with ERT, we observed some amelioration. But then with the vector starting from the lowest dose, in fact, 1 times 10 to the 11, we observed a complete normalization of the grip strength, which is a very good news, actually. Because, I mean, when I say grip strength, the relevance of these results is that with grip strength, you measure the force of a group of muscles. So whenever you rescue the grip strength, it means that you are rescuing anterior and forelimbs and the posterior limbs, and a lot of muscle groups, which is very important. Then you may think that we may be satisfied with these results, but in fact, if you consider, I mean, a dose in a mouse, how you compare two things that are so different. So a biodistribution of the gene therapy with a profile which is completely flat, and a peak and trough kinetics. This is not very easy, but there is a tool that you can use to do that, which is the area under the curve. It's something that is used in pharmacology typically. And to calculate the area under the curve is not that easy because you need to really have the curve for every treatment. And so this is what we have done here. This is not a cartoon. These are real data of the area under the curve after administration of ERT, of 9 times ERT, and the area under the curve calculate for the gene therapy. And the interesting thing is that you can calculate an area under the curve then, and here this is what we have done. And you see that there was, you remember, there was a similar efficacy of ERT and the lowest dose of gene therapy. And here you see that here in AUC is clearly, AUC, this is AUC measured in blood. you clearly see that they are almost comparable. And then you do see also an increased AUC with the dose, which I think is quite interesting because can be the fact that the AUC in blood is predictable of the efficacy in a mouse model, then can be very helpful in the future clinical trial. So just to conclude this, it can be also a take-home message. It looks like whenever you need to, the first thing is why we do that. I mean, why we improved gene therapy. Dwight showed already the results. Oh, where is that? Dwight is not there. Dwight already showed that liver gene therapy is efficacious, but why we need to improve? It's for the dose reason. Someone presented and said that we need to reduce the dose in adults, and so it's because we don't have the capacity to produce vectors for so many patients that we have. So this is why we work on this. We improve continuously the tools that we have because we want to reduce the dose. And with this approach, we obtained higher circulating levels of GAA and also a whole body clearance of glycogen. Also, one thing that really is important to say is that we were able to compare ERT with our secretable GAA gene therapy approach, and we observed a similar efficacy, if not an improved therapeutic efficacy, at 111 Vg per kilogram, which is a pretty low dose in gene therapy. And finally, another message is that the AUC in blood, it could be a good method to compare the efficacy of ERT and the gene therapy efficacy. In that case, it's in mice, but maybe that can be also helpful in the future human trials. And let me finish just by with the acknowledgement slides. So this work, of course, this derives from the work of Federico Mingozzi, who was a team leader in our group before, and moved from Genethon to Spark Therapeutics, and they are moving forward this approach to the clinic. But also I want to acknowledge also the work of Lina Colella and Francesco Puzzo and Elena Costa Verdera, who did most of this work that I'm presenting today. And all of you for your attention.